For patients with melanoma, with resectable melanoma, patients that start with skin primaries and then sometimes may have nodal disease, surgery is really effective, and a lot of patients get cured with surgery, but there's still a very high risk of relapse and death from melanoma. And so the new AJCC staging system has showed us that patients with stage 3 melanoma may have as high of a risk for some categories as 75% of dying of their melanoma. And so, you know, we are trying to develop therapies in that space to try to prevent recurrence and possibly death from melanoma. And so in the last year, there's been a couple of really important clinical trials that came out that showed that treatment with anti-PD-1 antibodies like nivolumab was actually safe. So it was about 15% toxicity, grade 3-4 toxicity rate, and was very effective. It was more effective than the standard of care at the time, ipilimumab, in decreasing the risk of relapse, and seems to be also overall survival. And so that was really important. That became a standard of care, FDA-approved regimen right now for those patients. And at the same time, a trial that had been done several years earlier and finally read out was with actually targeted therapy, so taking pills, dabrafenib and trametinib for patients that have a BRAF mutation, actually did decrease the risk of relapse and death also by almost 50%. So it's really great changes in that area, and so we now have 2 approved therapies. One is targeted, one is immunotherapy. They seem to be comparable in terms of efficacy, and you know, our patients now are benefiting from that a lot. So we actually put a lot of patients on standard of care treatment. What I also discussed today is actually kind of how do we think about the next, you know, steps in the field. And so we're thinking about bringing more effective therapy, so combination treatments for this population,